Uh, I would just officially like to welcome everyone. My name is Joan Devine. I am the Director of Education with Pioneer Network. And welcome to the virtual learning circle portion of our second Listen, Learn, Explore educational program. We hope that you enjoyed listening to Dr. McNicoll's podcast, and we are excited to be gathering together with more exploration of the topics that she presented. Our goal for this event is interaction and engagement. So we encourage you to turn on your camera and to set your Zoom to gallery view so you can see everyone on our virtual circle of squares, as I heard somebody describe it the other day. There are a number of ways to participate. You can certainly type in the chat, which some of you have been doing. Thank you. You can use the reactions that are down at the bottom of your toolbar. And of course, you can join in the conversation. So if you have something to say, you can raise your hand either physically or verbally, or you can just pop in. Now that said, I will ask that if you're not talking, if you could go ahead and mute yourself would be great. As I said, we are recording the conversation, and you'll get a copy of that recording tomorrow in an email that will come out to everyone. Let's get a few more people admitted in here. And at the end of the conversation, I did want to share too that we're going to post a short survey that we would love to have you complete and let us know how we did. And so that really kind of ends my portion of the talk. So without further ado, I'm going to turn this over to my good friend and colleague, Margie McLaughlin.
Joan, thanks so much. And thanks for your always effervescent energy that brings so much to the Pioneer Network. Hi, everybody. I'm so delighted to be here. I actually work for the Quality Improvement Organization in Providence, Rhode Island, Health Centric Advisors. And, but I get the better job of being able to be the chair of the Education Committee, and I get to work on a pretty regular basis with Joan Devine. And so as part of our kind of overhaul of some of our education programs, we decided to try the Listen, Learn, and Explore. And so we hope you're enjoying them. And today it's my great pleasure to introduce a good friend, Dr. Lynn McNicoll, who's an associate professor of medicine and is director of education for the Division of Geriatrics. Among the many things she does, the way that many of us have come to encounter her is she has been a great mentor and teacher to many of us. She's in and out of all of our local nursing homes and the hospital as well, and is even taking care of many of our family members. So it's my great pleasure to introduce somebody who really gets person-centered care and just doesn't teach it, but she also lives it through her work at the hospital and in some of our local nursing homes. So without further ado, I just want to turn it over to Dr. Lynn McNicoll. Welcome, Lynn. Hi.
Thank you so much, everyone, Margie and Joan, for inviting me to participate in this. This is a wonderful format for us to have a conversation, and I hope that it will be interactive, whether it's over the, if you want to speak out or talk through chat, that'd be great. Either way, we're hopefully going to make this interactive as much as possible. Thank you for muting. If we're not talking, that's great. Make some of the interaction a little bit easier. What I wanted also to say is that I know I'm a physician, and Jack and I had this conversation about us calling us Dr. McNicoll, Dr. Lynn, but I was also a CNA. I was also a physical therapist, and I've never been a nurse, but nurses and CNAs and therapists are my friends, my best friends, in fact. And I talk to Margie about this all the time. But they do all the work. They do the best work. They do all the sacrifices for our residents. And especially during the COVID era, it's been heartwarming to see how much sacrifice nurses and CNAs have done for caring for our residents and elders. I wanted to start with some good news from Rhode Island. So I looked this morning at our numbers, and we are 1/10 of the number of congregate living COVID cases compared to 2 months ago. So over 2 months ago, we had over 500 cases in Rhode Island. We're a small state, so you got to take that into consideration. But now we're less than 50. So we have gone from a crisis mode to a survivor mode. We are, and it is so heartwarming. I've been seeing the numbers go down with Margie for the last couple of weeks because we've been doing these echo talks regionally, and every time I do an echo talk, I bring up the numbers, and they've been coming down and down and down. And when I saw less than 50 this morning, I almost cried. I mean, this is tremendous, and it's all thanks to the vaccines, but also perhaps all the efforts that we've put in. But the effort in getting people vaccinated is tremendous. So I wanted to start with that good news, and I'm really hopeful that your numbers are coming down as well, and will continue to decline so that we can get back to somewhat a normal life. So I wanted to ask a question. I'm wondering, I presume some of you or most of you listen to the podcast, and what we really wanted to do is just give a basic not a whole lecture on delirium and sepsis, obviously, but a sense of what I felt was the most important aspect of managing delirium and sepsis in a long-term care setting or congregate living, and how we could think of it from a person-directed care. And a big part of the message was, in part, how we're identifying or screening or figuring out whether somebody's delirious. So I'd like to ask the group, what is your process for screening for delirium at your institution? Do you have anything formal? Do you use any particular tools? Any thoughts?
And
So
if
if
anybody
you,
wants to speak to that, just raise your hand and we can call on you, or
or if you,
unmute and just start talking.
or if you want, just go in the chat and we'll call up the chat as well if you feel a little shy about being on camera. So what's your process for screening for delirium?
And it's perfectly okay if you don't have any process and would like to think about it or talk about it.
That'd be great. We'll just give it a second, Lynn, to kind of roll in here. We're looking for folks. Let's see.
Is that why so many of you are joining us today? Because you're looking for one.
All right. What about any training related to delirium or sepsis?
How about that?
Is this
Hi,
something that
where I used to work, and I'm not there anymore, but we used to use the CAM for delirium. And that was the test that worked, and it was short and easy to administer. And what was the second part of the question?
do you have any formal training for delirium or sepsis?
And well, I've had so many jobs, but in one of my previous jobs, yes, we had, and I'm a nurse, we've had training in delirium, not sepsis.
Wonderful.
Lynn, I'm just going to share also that Lori Newberry was saying that she would ask for labs, CBC, basic metabolic profile, and the UA.
Wonderful.
That's kind of the road she would travel.
Hello.
Hi.
Tatiana, maybe you're trying to answer the question for
A
us.
vratila sam na sve. Ova kaže, kad je tako, tako je, pa neka.
Or not.
That's the joy of Zoom.
That's okay.
It's all right. Okay, so
Now, you know what I'm curious about, Lynn?
Yep.
Seeing folks are a little quiet on this subject. I'm wondering if we're in a place, could you type, if you don't do any screening, could you just say we don't, or put something in the chat to indicate how many of you don't have a screening process in place? just so
And-
we have an idea of like what's happening here.
And Margie Lozelle from Hebrew Senior Life typed in the chat that no, they don't have any formal training on delirium or sepsis, but nursing assesses patients' mental status and collaborates with the clinical team. And
Good. Jackie says no real process or policy and not really any formal training. Jackie, thanks for your candor and honesty. We appreciate it. And I'm seeing a lot now folks are not so much, Lynn. So
Thank
that's
you.
helpful for us to know.
Yeah, that is helpful. I mean, I think the hospital setting has been much more proactive in assessing delirium, and many of the institutions do use the CAM. And just as a reminder, the CAM is the confusion assessment method. It was developed by Dr. Inouye, who's actually now at Hebrew Senior Life and in Massachusetts. And Sharon developed a 9-part CAM, but then created the brief CAM, which I think we reviewed in the podcast, which are the 4 criteria: an acute change in mental status, so it being different than their baseline; inattention, which is extremely important, which is figuring out if somebody is paying attention to your questions or your conversation; disorganized thinking; and altered level of consciousness. And that can be being hyper alert or hyper agitated, or hypoactive, which is the one that we worry about the most. I'd like to start out by presenting a case. So this is a real case that happened a couple of years ago that led to what we formally did as a review, or what we call an M&M. And I don't know if any of your institutions actually do formal morbidity or mortality conferences. You know, we're an academic institution. We're affiliated with Brown University and in the School of Medicine. And our providers, we work with fellows and residents. So we use a lot of our negative outcomes to use them as teaching opportunities, but also learning opportunities. And we incorporate our nursing home staff, and we incorporate the nurses and the social workers, and if the case relates to a nursing home. And it's been a wonderful experience for us. And I was wondering if you guys want to talk about it, or put in chat whether you've ever done these in your institutions, and if you work with academic staff or not, or whether you've been able to do that. But I think it's a great way for all of us to learn. And the reason why I want to present this is primarily because it was a difficult case for us to go through. It was even more difficult for us to review in detail and talk about it, but it was also therapeutic. And we learned a lot, and we changed our systems because of it. And I think we've improved our care so that it's more patient-centered in many ways. So this was a 74-year-old admitted to the skilled rehab part of the nursing home after a hip fracture repair. Relatively healthy, few medical problems, other than you know, some hypertension, a little bit of diabetes. She'd been doing very well until she complained of some abdominal pain. They thought it was constipation, so they upped her bowel regimen to become a bit more aggressive. And then, you know, gradually over time, she started to eat and drink less, in part due to the abdominal pain, something that we probably see all the time. For a couple of days, she even refused rehab, wanted to stay in bed. And then the diarrhea began, but slowly, not terrible, not, you know, 10 bowel movements a day, just a couple of bowel movements. Then fever. And one day the CNA in the evening, always happens in the evening, right? In the evening, the CNA lets the nurse know that her blood pressure is 80/50. And she's a bit lethargic and sort of sleepy. The RN calls the on-call faculty. They start IV fluids, thinking she's a bit dehydrated. Of course, it takes a long time to get the IV. There's a significant delay of 3 hours before they can get it in. And later that night, her blood pressure is now 70/40. Sorry about that. And then she becomes unresponsive. 911 is called. She codes when the ambulance is there, but she's resuscitated. She's sent to the hospital, and after 2 days of trying to resuscitate her and bring her back, she actually dies 2 days later. In the hospital, they realize that her white count is up to 32,000. She's anemic with a hemoglobin of 8. Her sodium's 155, her creatinine 2.4. She's diagnosed with sepsis and delirium, found to be likely due to C. diff colitis, pancolitis. So not a great outcome. And that's why we decided to do a morbidity and mortality conference. And we incorporated the nursing staff in that conference, where we had a very frank and open discussion about what went wrong, what were the root causes, and how do we prevent this from happening again. And some of the issues that came up were that the resident, the resident had been sort of saying that she wasn't feeling well for a few days, but it hadn't really been addressed. So there was kind of a very slow process of, oh, she's okay. Oh, it's just constipation. Oh, it's just the pain meds. Oh, it's just a little bit of this, or it's just a little bit of that. And the anxiety level or the urgency part of her decline wasn't activated. Like, people weren't starting to feel worried about her. And so workup wasn't started. Treatment wasn't started. Things weren't precipitated fast enough. And then when it really started going bad, when she became septic, again, there was this sort of communication issues about, you know, how important this is, how sick she is, how we need to be more aggressive, how we need to raise the level of this management. And so the person was not, the care was not really directed towards what the patient was saying, what the CNA was saying, and things weren't initiated early enough to have prevented this negative outcome. So the conclusion for us was that, you know, she could have lived. We could have prevented her death. Had we activated things, had we communicated better, had the nurses used the proper SBAR format, had the on-call listened, all of those things, you know, at multiple levels, people weren't paying attention enough and weren't taking her illness seriously. So I'd like your thoughts about what, if this has ever happened in your institution, or maybe not in a death, but a negative outcome, and whether what in your institution you could or could not have done differently.
So what might be
Fascinating case study, Lynn, that you share, and I'll just start things out, and then hopefully somebody else will get brave and speak up as well. I see as a nurse that this could very likely be a scenario that could happen in any of our communities, and I jotted down as you were talking, you know, one of the Pioneer Network values is know each person, and certainly that is a core of a resident-directed setting and of a culture, and knowing the person helps you identify those nuances that individually may not be, you know, be the end all and the cure, but when we put them all together, when we see all those subtle differences, and when we involve the staff, the CNAs, the people that really know and see those differences, they can help us put that picture together in a much more effective way, so that we can address needs.
Yeah. You know, we have a lot of folks from Hebrew Senior Life not to put you folks on the spot, but how about over at Hebrew Senior Life? How does that resonate with you, and what might be different about the way staff work together? Anybody? Just kind of come off mute there. No pressure.
There we go.
Hi, my name is Larissa. I work on two Berenson with Russian-speaking patients. Can you hear me?
Yes.
Good. So on that subject, I just like to say that it's a team effort and working together, definitely. I'm life enhancement. Definitely collaboration with nursing staff and PCAs important, because everyone has access to patients on different levels from different angles. And if we see changes in behaviors or the way patients communicates to us, it needs to be a way of communicating that with each other. Because if PCA noticing something, if something is off, it's their responsibility to go to nursing staff and talk about it, and they have to register it and communicate to doctor. So that's important, but from my observation, it's not always happening.
Right.
So
Thank you so much. And where do you think those problems are happening in terms of the communication? Why is that?
I'm definitely, I'm just, my experience is more observational. Since I'm life enhancement, so I just have access to notes, for example. Sometimes I don't have time. So I have 60 patients on the floor. And so we are busy with our own schedule, and if something comes off beyond our typical schedule, it's really difficult find a way to communicate to everyone. I don't. It's a good question. I don't know.
Okay. Well, thank you for speaking up, and it's, as you say, you know, if you're really busy with 60 other people trying to figure out whether one person has a change is difficult. Any other thoughts from anybody else?
Well, I can speak as a resident. I've lived where I live now for over 14 years, so I've seen a lot of people perish, some under questionable circumstances. I think it's very difficult to distinguish just the routine anomalies of old age, dementia, etc., from what's something that's physical and very acute. And I see that there are structural challenges in the way the industry approaches things. To begin with, as we've been listening to this communication dialogue here, there's the healthcare model, and when we're talking about these things, we're moving into the healthcare side of old age, is very hierarchical. And so there are these knowledge workers at the top and there are relationship workers at the bottom. And it's very hard for those at the bottom to get the attention of those at the top. So that's a structural problem. And since my career was as an actuary, I tend to look at those concerns. But also, I've noticed that with geriatricians, particularly geriatricians who work in the PACE environment, which I think is a absolutely wonderful approach to these questions, those geriatricians do build relationships. And one of the first things that geriatricians seem to do is to take stock of all the medications that have been prescribed over the years. In my case, for example, over the years, I've been prescribed 11 medications. I take 11 things every day. And the way our medical system's structured, there's no way for the doctor to come back after the fact and say, well, that prescription, periodically they may review. They'll say, well, I want to see you every 6 months or every year or something. But in general, once the doctor has taken action, there's no follow-up to see how it worked, except in case-by-case situations like the one you're talking about now, where we go deeply into one case, much as the National Transportation Safety Board goes into the case of a Pratt & Whitney engine that falls apart. So there's this challenge between the human relations side of medicine, particularly as it relates to the very elderly, and the science side of medicine, which is the knowledge side. And they don't seem to come together well. And so I think there's a real need for structural reform in the way we view the elderly, the way we approach these common ailments. I think my experience on the specific things that you're talking about now, we've all known about sepsis for some years as a rising cause of death, which just means that physicians increasingly denote that or on the death certificates. But the delirium is the correlation of delirium with dementia and medication and other factors like diverticulitis. I mean, just listening to your case, that sounded, diverticulitis can escalate into bowel obstruction. Well, you sure want to know about that mighty quick if it happens. And but if you're in a place where your job is to make caring for failing older people routine, that may not jump out. And so I think there are some real
Jack, thank you so much, Jack, for those comments. That was wonderful. And what I heard from you was a lot of issues, systemic issues that are one of the failings of our system. The organizations have to survive financially. It's often very difficult for them to provide optimum amounts of nursing and PCA staff to be able to go beyond the purely medical routine, must give this drug at 8 p.m. to being able to provide a holistic approach. To be honest, it's the same thing with the medical staff. They need to survive financially, so they need to see a certain number of people. Unless you're in a system where you're paid to provide great care overall, which is like the PACE model. And I think thank you so much for bringing that up, because that's a model in which they try to combine the entire care model for optimizing that individual and bringing their quality of life, their patient-centered care, everything, their polypharmacy under control, so that they are as independent and as happy for as long as can be. There's an issue that came up, Lori. Thank you so much for bringing that up. The issue of trust. Does the CNA feel comfortable either bringing something up to the nurse? If the nurse doesn't listen, does she feel comfortable insisting? I said she, could it be he? Sorry. Does she or he feel comfortable insisting or bringing it to the next level? Do they feel comfortable with their own assessment? And relaying that importance to the physician. If the medical staff, whether it's a physician or nurse practitioner or PA, don't really see that there's a problem or they're dismissive, does the nursing staff feel comfortable addressing it? And in some ways, you're being an advocate for the resident, right? You're bringing an issue on behalf of the resident to make it an important issue. Is that happening in your, what is the culture in your institution so that people do feel comfortable bringing it up? I remember a situation in which there was a cardiologist, not to pick on the cardiologists, but there was a particular cardiologist who didn't have the best bedside manner. And the nurses dreaded calling this particular person for issues. And I had to intervene, in fact, and insist and have an intervention with the cardiologist and with the cardiologist's boss related to this issue so that it didn't lead to a medical error or a consequence of somebody not addressing those issues. So that's not unique to my institution. I'm sure that happens in a lot of places. And how do we bring all levels of staff, whether you're a cleaning lady who or man who identifies that somebody doesn't look quite right, and bring that issue up to a nurse, or feel comfortable doing that and feel like they've been heard and understood. Anybody have any thoughts about how you've addressed this in your institution in terms of the culture change related to trust and comfort at bringing important issues, whether it's delirium and most importantly sepsis, to a higher level?
Let me jump in here again, because first I want to say that I'm an actuary, so I look at money. And you mentioned money as a factor in the PACE program. From what I can see, delivers the care at half the cost of the general Medicaid system. But having said that, what you were just saying, I had a friend who he had a cardiac incident, and the doctor told him that he had likely a month to live. That his heart was that damaged. So he decided, why prolong it? So he tried to stop eating and drinking. And he was doing pretty well with it, although the stopping drinking bothered him. He had a gelatin stick, but he just got the dry mouth bothered him. And the nurse, the director of nursing, who was a graduate of Columbia Presbyterian Cornell Medical System, didn't think he was going to die, but the doctor, who is a graduate of the American University of the Caribbean and had the authority, gave the orders. And so my friend was there, and he was really to take his life. But he had a friend from a discussion group who had been a physician in Russia. She's not allowed to practice in the United States, and she never did really find employment here. But she came in one day and she said to him, get out of bed and sit in the chair. And he got out of bed and he sat in the chair, and he began to think he was going to be okay. And finally, that director of nursing spoke up to that doctor from the Caribbean and said, I think you're wrong. That takes real courage, because doctors are superior to the most well-trained nurse. And my experience is that there isn't the natural distinction there that the structure of the system is giving us. And what the power of the PACE program is that it begins to break down those hierarchies. But that, because that goes against convention, there's pushback against the PACE model, which could work for all ages. It's a very good model. I call it relationship medicine. Our medicine today is reactive. The patient comes in, there's a complaint, there's presenting conditions. The doctor reaches a conclusion and gives orders, and then that's the end of it. That's reactive. Relationship medicine means the doctor knows the person, and is able to discern some of these things. So I think there really is potential to do better than what we're doing if we open our institutions to new models of thinking about what's needed to provide for our populace.
Thank you so much, Jack, again. I think that some of this is also collaborative decision making. So working with nurses to come to a diagnosis, to come to a plan of care, to come to a consensus. It's shared decision making is another term that people use. And we use that a lot. We need to be able to together come up with a plan of care, and everybody's comfortable and has agreed to that plan of care. If somebody is not comfortable, then they need to speak up.
Lynn, I
Carol,
just want to point out that Carol has put a beautiful thing in getting accolades. We taught staff to use cuss words, C-U-S. C stands for concerned. I'm concerned about ... U is for uncomfortable. I'm uncomfortable with, or just say stop. So concerned, uncomfortable, or stop is a great cuss word. So I
no
think
pun
that's
intended.
it's a beautiful thing.
I love it.
Lynn, one of the homes that I work with, they had in helping to develop trust, whenever there were any kind of meetings that involved cross-disciplinary type meetings, everybody had to take off their name badge. And the director of nursing used to say, when you walk in this room, we're all equals. And so we're all going to take off our name badges and we're all going to be on an equal playing field. So there's no hierarchy in this room. And that was the start of something really big and something really important as they began to really encourage junior staff, if you will, to be able to talk up to the powers. So kind of well worth it. I don't know if other people have examples of how people have been able to get trust a part of the environment and part of the basic culture. What are some of the ways that you've helped to invite and create a trusting environment? What are some of the things you've done?
I know that somebody is from the greenhouse project in Florida, I believe. I work in a greenhouse as well. I'd love to hear your thoughts about how that model helps to create a trust environment.
Not sure who had the other person that, I don't know if I put you on the spot as Jackie, because I know at your community, trust is something that is integral to your culture.
Yeah, so trust and building relationships are really, I don't want to say they're the only thing we do, but they're what drive everything that we do. If we don't have good, deep, meaningful relationships that are trustful, and it's a reciprocal trust, the member trusts me, I trust the member, and we're in this relationship together, and we're not honoring what our member wants from us, then nothing works. You know, we stop, you know, and say, okay, what do we need to do to make this work? And so our days are filled with more relationship building than being task oriented. That's what we do. It's just all about being in relationship, and that builds. And you can't have a great relationship with anybody unless you build trust. I'm going to let you examine my body in parts that nobody sees unless I trust you and we have a great relationship. I'm not going to let you give me a shower or help me toilet or even trust you to say that you're going to send me somewhere for more medical care unless I have a good relationship with you. And I know that you are helping me live my best life. And that's what we're here to do for each other. So thanks for that, Joan.
Thank you, Jackie.
Lynn, I just want to point out that your fellow greenhouser is Carol Stryker, who was the person who gave us the cuss.
Thanks, Carol. And somebody also mentioned listen, support, and smile. I love that. Just smile.
Yes.
Even if you're on the phone, the smile carries through in your voice. And Carol also wrote, we work together and do not focus on blame, which is really important. We work on failing forward and learning from what did not work well. We use consensus and exploring options to collaborative problem solving. Wonderful. And thinking outside the box. I mean, I know it's a little tacky, but it really is important to think outside the box when you're dealing with different unique things related to older people and who are in a vulnerable position living in the congregate living where we work.
I was just going to add, Lynn, I think the conversation that was a little bit offline before things started when you and Jack were talking about, you know, what to call people. I had shared this actually with Jack earlier this week, that one of the medical directors that I've worked with in my career, who I truly respected. And he, just like you, Lynn, he started out as a CNA. And in our very first visit, one of the first things he said to me was, you know, what do you want me to call you, Joan or Mrs. Devine? Which I said, you know, Mrs. Devine is my mother-in-law, so Joan, please. But then he also said, well, and I'm Dave. And that's the first time in my career that a physician or a medical director had made that invitation to that level of relationship, that it's Joan and Dave. And he's the same physician, he's the same medical director that when he would come into our skilled nursing, the first place he went was to go talk to the CNAs and to find out what they had seen, what from their perspective was happening. And I thought that was many years ago. It was in the early days of the culture change, the person-directed movement, but he was certainly ahead of his time.
Yeah, but by the way, if I may, I had a question for you all, because there's a topic that hasn't been discussed here, and that is compliance. We have very elaborate regulations governing what's acceptable in this environment. And I haven't heard anybody talk about the challenges of compliance and record keeping. Does that support the goal of a healthy clientele and long life, or does that inhibit it?
We could probably have a very long conversation about this and end up with migraines across the board. It's a bit more complicated. I think when it relates to delirium and sepsis, the only thought I had, at least one of the thoughts I had, was that it's really important to document in the chart what changes have happened so that you're communicating from member to member, from nurse to nurse, from nurse to physician. I do rely on what's documented as much as I do, if I can, to what's going on with the nurses who are in charge at that very moment. So the nursing homes are very good in general at complying with rules. The issue is that there aren't any very specific rules when it comes to delirium and sepsis that I can think of. Anybody correct me if I'm wrong?
Not any that I can think of. Hey, Lynn, when we were talking earlier, you had a brilliant quote, and when you described that case study, and you said that folks didn't activate their sensors. Folks didn't activate their sensors. And I thought it was a beautiful description of like when people are working so hard and kind of tuned out, inadvertently tuned out. In the midst of COVID, when people have been working really hard and are really burnt, that's kind of a, well, I'll let you say.
Well, actually, why don't we talk about the second case? I think that's a good tie-in, because I did want to bring one case in, and maybe this kind of situation will never happen again, and let's hope so. But this is a case of it probably is a conglomerate of many patients that I saw, many residents in the facilities during some of the COVID outbreaks that I've had to manage. But this is, let's say this is a 94-year-old long-term care resident, female with moderately advanced dementia at baseline, hemiplegia from CVA, generally able to make her needs known and generally able to have conversations. And as soon as you walk in the door, you've got this big beaming smile on her face. And of course, that always makes my day. So I'd always love to visit this particular resident. She'd been stable, doing well, tolerating quarantine and isolation relatively well until she got COVID. So as many of you have had to deal with, once somebody got COVID, they got moved to a different unit. And I don't know if you said the same thing, but before this whole thing started in February and March, when I was having conversations with residents and family members, I would say, you know, if they get COVID, you know, they'll be home, they'll be in their home, they'll be taken care of by people who know them. And that was actually the hope that, and then that you know, we'll be able to be advocates for them during their COVID infection. Of course, none of that was true, right? They got moved to a different room. So for them, their world was completely different. They got taken care of by nurses and aides that didn't know them or didn't know them well on a different area. And this particular person ended up losing 8 pounds from not eating and drinking well during their COVID, recovered formally from COVID, but they were, again, started to become more sedated than normal. And then 2 weeks after having recovered from COVID, I walked into the room and she's again changed to a second, another unit, which is not her regular room because of all the shifting room changes. And she's minimally interactive. She's not smiling. And we ordered some stat labs and her sodium's 159, her creatinine had bumped up from a normal to 2.5. So we diagnosed her with severe dehydration, started crisis because nobody there could start an IV properly. Of course, you know, with crisis, we can't really get a lot of fluids in fast enough. Her advanced directives were DNR, DNI, DNH. She did eventually improve in terms of her lab and her condition. But as I mentioned, I saw this repeatedly during one of the huge outbreaks that we had, especially in the spring, where people didn't officially die from their COVID, but they had a huge decline because of COVID. Whether it was staffing changes, you know, we didn't have enough nurses, we didn't have enough aides, they didn't really know her that well, or you know, they're isolated in their rooms. People who needed more attention didn't get quite the attention that they needed. She was essentially delirious and she was hypoactive. She wasn't bothering anybody. She wasn't screaming and yelling. She wasn't giving any trouble. She wasn't crying out for attention. I'm having trouble. I'm not drinking. I'm dehydrated. And even though in her baseline, she was able to articulate her own needs, give her a little bit of dehydration and she's no longer able to say, I'm thirsty, I'm having trouble, I'm not feeling well. And so this person can quickly deteriorate. And, you know, over time, I saw a lot of these people who didn't quite make it weeks or months after their COVID diagnosis. But as I say, they didn't die of COVID, they died because of COVID. And I'll really be interested to see how many of our residents have had excess deaths because of the entire process of COVID and what happens. And on top of that, of course, you know, the families weren't able to be there to be her advocate. They weren't really appreciating the changes that were happening to her. And, you know, they weren't able to FaceTime with her soon enough during those last few days when she deteriorated to really be able to see, oh, there's a problem here. You need to activate your sensors, like I said earlier with Margie. And so I wanted to bring this up. I'm hoping we're not going to have any more outbreaks, but it's possible that we will. And maybe not as big as we used to. There was one facility Margie and I were talking to in January that had 70 cases within 3 weeks. That's devastating. I don't know what I would do with 70 cases of COVID in a 3-week time frame. But hopefully those things don't happen again. But if they do, we might see these kinds of people again. We might see this scenario where people aren't totally symptomatic from COVID, but deteriorate because of it. And so I'd like your thoughts. What you would have. Is this a similar scenario that you've been through, or not, or how would you have dealt with it in your facility?
Give folks a minute to put some thoughts in the chat there, or even open up their line and maybe share a thought or two.
It looks like she had to leave, but earlier Meredith was with us from the Eden Alternative, and many conversations over the last year that we do, for those of you who know the principles of Eden Alternative is that helplessness, loneliness, helplessness, and boredom are 3 of the things that truly impact quality and life for elders. And so many conversations about how those were as devastating as the virus itself in some cases, that people gave up, that or just as you shared, Lynn, in that story, we didn't see the whole picture always. And when we've all seen people that just give up, the failure to thrive, and that probably many people feel that when we look back over this last year, we will see that was as devastating as the virus.
Absolutely. We've talked about some ways that we've been able to overcome this. But I think that if we could have been able to keep the knowledgeable staff in her care, some of this would not have happened. If there was a way that we could have the folks that knew her in her care, sufficient staffing, and of course, some of this in retrospect is easy to criticize, but having people who didn't really know her, and I mean, I would. It wasn't unusual for me to talk to a nurse. I would typically, when I'm going into the COVID nursing homes, I would go to each unit and talk to each of the nurses on those units and say, okay, what's going on? Who's sick? Who's not sick? Who's recovered? Who's failing? And they would say, oh, everybody's fine except these 2. But then I'd go see this 3rd person, and they'd be sick like her. And the staff had no idea that she was so sick, because they thought that was her norm, and not knowing her normal almost killed her. And and it made me, I know that a lot of facilities, their providers, their medical staff never came into the facility. They all did televisits. And I couldn't bring myself to do that because of exactly these kinds of situations, where I would go into a room and somebody that I knew was bright and smiling was now no longer minimally arousable, and this was different, and this was a change, and this needed to be addressed like right now, aggressively. And so, how would we do this differently? Again, I would, try to keep the staff stable. A lot of people have given some great suggestions on how to optimize communication, whether it's SBAR or CUS. I love it. But it's not just from the CNA to the nurses, but the nurses to the medical staff. listen to your elders, anticipate problems. This is what geriatricians do best. It's really to anticipate problems and try to prevent them, which makes it hard for us to prove a negative, because if we do our job right, nothing happens. And nothing happens meaning, you know, they're happy and they live their lives as best they can, but nothing bad happens. Really to be very aware of hypoactive delirium. And if somebody's quiet, that makes me worried. Especially if somebody has not been normally quiet. And really knowing, you know, I tend to be kind of calm, cool, calm, and collected, kind of. But every once in a while, I need to say, "Oh, wow, no, this is important. This is different. This is sepsis. This I need to be aggressive." And knowing when that is really the skill. That's what we learn over time. And we all need to be that way, from the CNA to the nurse to the medical staff. We need to know when we need to rev up that urgency. And if they're a full code or they're do not hospitalize, then in many cases with sepsis, you need to send them to the hospital. If they're do not hospitalize, then you can still do a lot of things in the facility to try to keep them in their home and keep them healthy. And bring them back to a healthy state. So I know we only have a couple minutes. I wanted Joan to give you a couple minutes, or if anybody had any final thoughts.
And Joanne and Lori, that's a great comment. The biggest role in care of our patients is the CNA's role. Directly staff who need good special education, sepsis and delirium. And I think sometimes we don't include them in that level of education. And some of the best education I've ever been involved with was when you bring the whole team together and you discuss things as a team, including the physician, and learn from different people's perspectives. And then you learn to appreciate what each one brings to the table.
Great.
CNAs are terribly underpaid and
Yes.
underappreciated. I agree with that. But I wanted to touch on something that Lynn brought up in her podcast, which was that many people my age know we're going to die. So our goal isn't prolongation of life. We've accepted that life is going to have a terminus. And so when the COVID first came up and there was a insufficiency of resources, many of us said we would not want to go to a hospital because we wouldn't want to take resources away from younger people who still had their full lives ahead. We would rather just be made comfortable and let life end. And that's not a terrible, frightening thing for most people our age. I know with my mother, she was 96 years old. She lived the last 12 years of her life in a nursing home. Finally, she had spent down all her own money, so she had to go on Medicaid. And because of that, she no longer had her hair done. A lot of grooming things disappeared. And so she decided to take her life, which she did by not eating. And my niece went and tried to get her to take some nourishment. And my mother, with great strength, just pushed the hand away. And she chose to die that way. And of course, that was called failure to thrive. And I'm not sure that that's completely irrational, because living with the indignity of some of what the Medicaid reimbursement imposes may not be a life that somebody really wants to prolong. So, and I think that suicide is a big factor among the elderly, and there's constructive suicide and destructive suicide. I think we need to distinguish that, but there are some people who just choose not to go through it all and to let it end. So I'll just throw that out.
Thanks, Jack. Although that was a very sad note to end on.
Well, I apologize for that. I'll just say this. You're all heroes. We who are residents value you. We observe a lot, and would be wonderful if we were also part of this and listened to. I know that HIPAA supposedly says we're not supposed to be part of the process, but the residents do care, and many residents are still functional beings and still contributing. And I look at the people like, I was looking at Senator Grassley the other day, 87 years old. He'd be perfect resident material, but he's choosing to matter, and Joe Biden choosing to matter. We've got to change the way we think about the elderly, and you're all heroes in being here and thinking about it that way. Is that a better note to end on?
Absolutely.
Absolutely. Well, and on that, it is right on the hour. And I want to thank you all so very much for being a part of this conversation. We never know how they're going to go. This one has been just intriguing in so many ways. Lynn, I would guess that just about everybody on here who is a nurse would love to see you on their medical staff in their community. I would have loved working with you. So I just, in conclusion, let me throw a little bit of housekeeping in. As mentioned at the beginning, I just placed a link to a short survey in the chat, and I encourage you to give us your feedback. And in addition, you'll get it in an email tomorrow with a link to the conversation recording, just in case you missed something. Be sure to watch our next Listen, Learn, Explore, which will be hosted by Dr. Rosemary Leard. She's going to be exploring the connection between, are you ready for this one? Urinary incontinence and person-directed care. And yes, there is a connection there. And I think you'll all get it. The podcast is going to launch on March 4th, and then the Learning Circle is going to be on March 18th, but there'll be lots more information about that that you can find on Pioneer Network's website. And I'll give you a link to that as well. And so be sure to check out on our website upcoming events. We're so delighted that you were a part of this conversation. We know for those who spoke up, that was wonderful. For those who chatted, that was great. For those who stayed with us and listened, that was remarkable too. So thank you so much for being part of that. Thank you, Dr. McNicoll, for a wonderful podcast that's still out there and available for people to listen. Excuse me. And thank you to Margie for helping coordinate all this. I hope you all have a great day.
Thank you, everyone.
Thank you, Joan. Thanks, Lynn. Bye, everybody.
Bye, everyone.